Normal labor per vaginal examination. This video is in English as someone asked for it. While monitoring women during the second stage of labor, we conduct per vaginal examination. So, what do you know about second stage of labor? Second stage of labor starts from the complete dilatation of the cervix to the childbirth. Do you remember that complete dilatation of the cervix indicates 10 centimeter dilatation? So, why do we conduct this per vaginal examination? Just to check whether the pelvis is adequate for the delivery of the baby and check whether the progress is normal and in which stage she is in. Every 4 hours, you need to conduct the per vaginal examination just to avoid the infection. Remember, don't conduct the per vaginal examination if the patient has pain or constrictions because that may give you a wrong reading. And if the patient has bleeding per vagina, especially in the cases of placenta previa, otherwise abruptio placenta, you may induce by doing PV. So hence you are not supposed to do per vaginal examination in those patients. Arrange the place and instruments for the delivery. Per vaginal examination is a systematic examination of the lower reproductive tract. So that indicates cervix as well as vagina and the lower uterine part as well as the pelvic bone part too in relation to the pregnancy and labor. What are the equipments required? You need a small sterile bowl just to pour the solution 70% Savlon into that, and you need gauze pieces to pick up by the sponge holder and the dissecting forceps to squeeze it if your excess is going to be there. Savlon, and you need a pair of gloves with the jelly too. Explain the procedure to the mother if you want a good cooperation from her. Provide privacy by keeping the screen around her just to give the respect to her and her feelings. Assist her to empty her bladder by asking her to go to the toilet. Position her in the lithotomy position and wash your hands, wear the gloves, give a perineal care with antiseptic solution. Lubricate the fingers with the Savlon jelly, otherwise silicone jelly, just to prevent the friction. Introduce your middle finger as well as the index finger for examining the hand into the vagina. Remember, if you're going to insert your index finger, if it admits one finger, it means 1.5 cervical dilatation. If the cervix admits two fingers, it means the cervical dilatation is around 3 to 3.5 centimeter. And this is the way the cervical dilatation has to be checked. And this is the vagina, this is the cervix. You have to stretch and check for the distance. Okay, when the fetal head comes down, this will be distended more. Encourage her to take deep breaths and relax during the examination, otherwise she may have pain. Assess for the effacement, dilatation, position and consistency of the cervical factors. So let me know about what is effacement is. Effacement means it is a taking about the cervix means uh, the cervix will be taken into the lower uterine pole. It will merge. This is primigravida is the first pregnancy mother's cervix, and this is multiparamus. She already delivered one child, so her cervix will be like this. So this is before the labor. Look at the length. The length will be the same, 4 centimeter. The length of the cervix will be 4 centimeter. But thing is, it's closed over here, right? But here it is a bit patulous, means it is relaxed, opened in the multipara. So slowly there will be decrease in the length of the cervix, but it will merge, the cervix will merge to the lower uterine segment. Again, this is only 1 centimeter, and finally this is 0 centimeter. So this is called as an effacement. So the upper pole will be opened and merges with the lower uterine segment. And if the lower pole is going to be dilated, this is called as a dilatation. The upper pole effacement, the lower pole is dilatation. So this will be dilated and this will be up to 10 centimeter dilatation. Okay. So for 12 hours, the first stage of the labor in primary gravida occurs. Why? Can you look at the cervix? It takes long, quite time for dilatation. So look at the dilatation part. Effacement is occurs before the dilatation in primary gravida, but both simultaneously occurs in multipara. So the position of the cervix, normally throughout the pregnancy, the position will be at the posterior side, and it will come in the middle line in between the progress is going to occur, and it will come to the anterior part if it is going to deliver. Okay, and consistency is a softness, whether the cervix is soft, otherwise it is firm. That has to be checked. If it is going to be firm, it does mean that the labor is not progressed. Soft, here they call it as a cervical ripening. Ripening is a word we could understand, right? This meaning is matured. So check for the conditions on the membranes. If the membrane is intact, means it is not ruptured. So you can find the four water bags, and we won't see the hind water bags. It will be bulging like this, and this is called as a rupture of membrane. So amniotic fluid color noted if it's going to be rupture of membrane. Okay. Normal color is clear and tinted yellow. It's like a serum color, urine color. And meconium stained if the baby has fetal distress. Meconium will be green in color. Fetal distress means the fetal heart rate is up and down. It's not in normal range. Okay. But in some presentations, what happens is like breech and transverse. Uh, it may occur also, and sometimes if it is in breech, you consider it as also normal because it's somewhere in the front part. Okay, depending upon the degree and the duration of the distress, the amniotic fluid may have flakes. It might be thin or thick or piece. So flakes are nothing but just like thread sort of things. If it has a thick with the presence of flakes, it means that there's a chronic fetal distress. Golden yellow color if RH incompatibility. RH incompatibility, the mother will be having the negative blood, RH negative, and the baby will have a positive blood. So in that case, if it is going to be the first pregnancy, much won't be affected. But in second pregnancy, the fetal RBCs membranes will be broken, and that is called as a hemolysis. So ultimately it leads to increase in bilirubin, and that is why the patient has jaundice. So that will be in golden color. Greenish yellow saffron color and post maturity indicates more than 42 weeks of gestation. Dark red color, it's a fresh bleeding, might be because of the accidental. And if it is going to be dark brown or tobacco juice, it means it's old bleeding, frequently in presence of old hemoglobin, adult hemoglobin. Otherwise, it is in case of intrauterine death. Okay, check for the conditions of the presentation and the presenting part of the fetus. What do you mean by presentation? The lower pole of the uterus, whatever the fetal pass is there, that is called as a presentation. So this is a normal cephalic presentation. It is cephalic presentation. Mal, the word mal itself says it is abnormal. Okay, abnormal presentation will be the face presentation. The face will be at the first part to deliver, and this is the eyebrow will be the first part to deliver. Compound presentation means it is more than one presentation. For example, this is cephalic presentation is number one presentation. Number two is the hand prolapse. So look at this. Okay, cord presentation. Cord is coming first at the lower pole of the uterus, and shoulder is over here. This is an anterior part, and if it is going to stay behind, it is a posterior part. Breech with the extended legs, and this is called as a flank breech. And flexed breech is the complete breech, you call it as, and foot link breech it is. So check for the condition of the position. If she's going to stand like this, the pelvis will be like this and the position also will be like this. So let me know about this. The normal positions are two positions, LOA and ROA. So it is left occiput to anterior. How will you know that? Can you identify this? This is a fetal skull, occiput, and mother is on left and this is on right. So that is why anterior means if this part is going to be anterior and this part is going to be posterior. That is why it is P, P and P. Okay, if it's going to be on the right, it is right, on the left, it is left. And here, mostly normal vaginal delivery is not possible. But here, this way, ROA and LOA, it is possible. Sometimes transverse also is not possible at all. This is a normal position. The fetus will lie like this and the back will be in the front. But in occipital posterior position, the fetus back is at the mother, it matches with the mother's spine. Check for the degree of molding. Molding means overlapping of the bones. When the fetal head comes through the mother's pelvis, both are bones, right? So one has to give a way. So there are sutures and fontanelles in the fetus so that the baby can come out very easily. That is called as a molding. So here the parietal bones overlap with the occipital and the frontal bones. Can you check that this is a parietal bone, this overlap with the occipital and the frontal bones also. Okay, molding can decrease the biparietal diameter. Biparietal diameter is 9.5 centimeter normally. So when it is passes through the mother's pelvis, it will decrease by 1 centimeter. It will be around 8.5 centimeter. That's it. Okay, it's up to two grades occipital post parietal molding may be there, but it depends. 3 grading is also present. So this is the way. In simpler way I could teach you is here the bones there's no overlapping. Here there is somewhat overlapping and that is not affected, but here plus second degree overlapping is there, but it comes very slowly back when the contraction is been gets back again, and overlapping is more, especially in fetal death only this third degree will occur. Let me explain you. Wait. Okay, so this is a degree of molding, and here you see this occiput. Okay, this is a fontanelle, right? So when you touch there, sagittal sutures are not overlapped, and here there is a bit, there's no gap, right? So this is one molding, and here it is already overlapped, but when you touch it, it gets back again. So that is second degree molding, and the third degree molding is there may be a fetal death or something like that. And that is why it's so severe, the bones are overlapped and it is not coming back. Check for the station. It's common, right? The station means like it's a connectivity of both the things. Whether it's going to be a railway station or bus station. So here also the station means it's connectivity. We're going to assess whether the labor is in progress. How do you check? This is ischial spines. Okay. Here you insert your hand and you touch it here and there so that you will be able to find if the fetal head is over here, it is 0 station. If it is above that, -2, -3, -4, -5, and if it is below the ischial spines, it is +1, +2, +3, +4. Okay, approximately only we can measure this, and with this we'll be able to know how the progress has been occurred. How far it has been occurred. Okay, remove the fingers from the cervix and introduce into the pelvic cavity, because to identify whether it is a gynecoid pelvis or female pelvis. So how will you detect? So detect all contracted pelvis. If the pelvis has been contracted, the fetal head will be somewhat overlapped like this. Okay, that's why you need to check whether the pelvis is adequate. You have to check it from the brim, the top of the pelvis, mid pelvis, and the outlet. In the brim, you have to check for the diagonal conjugate. So diagonal conjugate is a measurement between the symphysis pubis, lower border until the sacral promontory. Um, so here is the sacral bones, and this is the tip of the sacral promontory. That the first bone is called as the sacral promontory, and this is the symphysis pubis, lower border of the uterus from symphysis pubis. Sorry, here the distance is measured, and that is supposed to be 12 centimeter. You know what happens? It's difficult to stretch and find it out the sacral promontory because it is a bit lengthy, right? I don't have 12 centimeters of length of my fingers. Even I middle finger also I don't think it is 12 centimeters. So it is very difficult for us to check for that. But still, as a part of assessment, you need to know about this. You need to check for the obstetrical conjugate. Uh, Obstetrical conjugate is you need to subtract the same 12 centimeter by 1.5 to 2 centimeter, so that you will be able to find. Why do they check this? Because suppose if this is going to be the symphysis pubis is 4 centimeter, this is in the front part, and if this is going to be the back part, okay, this is the back of, this is sacral bone, and here this is sacral promontory. So what happens is here the lower border till this I mean the tip of the sacral promontory will be assessed, but behind the symphysis pubis in the middle part there's one elevated part. Okay, this is the distance you're supposed to know, because if the fetal head is going to come here, it has to get through this, and if it is going to be prominent or it is going to be very big or something like that, it there's no chance for the fetal head to pass through. Hence, you're supposed to see through this. And if the middle fingers fail to reach the sacral promontory or touches it, it is difficulty, and might be there's likely that conjugate is adequate for a average size baby. If the baby's head is bigger, it is not possible. That's why we are supposed to check that. You need to check for the posterior surface of the symphysis pubis. Posterior surface, anterior surface is this front part. Posterior is the back part of the symphysis pubis has to be checked. You have to check it for whether it is smooth, rounded curve, and if there is angulation or break or something like that, it suggests abnormality. Check for the iliopectinal line. Okay, this is iliopectinal line, and check whether it's narrow, to find out android pelvis. Android is heart shaped. This the brim, right? This brim, if it is going to be in a heart shape, you will be able to identify this android. By touching this, you will be able to identify it as narrow. Then in mid pelvis, you have to check for the sacrum, whether it is going to be. Usually, it is not tipped. This is sacral promontory, and this is a 5 bones fused sacrum. Check for whether it is long or straight, and check for the ischial spines. Check it on the both the sides, just like this. Check whether it is adequate, and it is difficult actually. It should be blunt. It's not smooth, it should be blunt, and but it should not be sharp. Sharp means it is prominent, you call it as, okay, because if the fetal head is going to come over here, it will encroach over this, so then there'll be delay in the progress. So check for the interspinous diameter, which is also called as a bispinous diameter. Is nothing but is the distance between both the ischial spine. This is around 10.5 centimeter. If it is less than 10 centimeter, it indicates that it's a contracted pelvis. Sacrosciatic notch. This is sacrosciatic notch where it admits two fingers. Okay. Uh, this will say that the posterior part is whether it is normal or not, and check for the side walls whether this is normal, otherwise it's narrow, something like that. Okay, it should be parallel and divergent. Parallel means this, divergent means might be it would have started somewhat like this, convergent, and then it became diverged. Okay, check for the side walls of the outlet, and check for the sacro-occipital joint whether this is taped or not. This is 4 bones fused coccyx. Check for the mobility. Okay, otherwise it is hooked. Check for subpubic arch. Okay, So this is a pubic arch. Suppose, for example, imagine, okay, it is a fetal head and the bilateral diameter is 9.5, but they have kept a disc over here and they have said it is 9.3 centimeter, and there's some space in between this space is called as a base pair of morus. It should be not more than 1 centimeter. If it is going to be more than that, it means the pelvis is narrow. Okay, so it admits 2 fingers normally, but if it is going to be 3 fingers, it is adequate for the outlet. Okay, so this is what this is base pair of Morris is like upper border of the symphysis pubis and the lower border of the symphysis pubis. There's a bit of yeah. This is symphysis pubis, and this will be the space at the lower border of the symphysis pubis, and it will be normally 1 centimeter. It should be not more than that. Check for the subpubic angle. So it should accommodate 3 fingers, just like this, and if it is going to be 2, it means narrow, and it should not be the 90-degree angle. If it is going to be in the 90-degree angle, what happens is it shows that small pelvis. So the pubic rami, this is a pubic rami. You have to check the distance between both by keeping your thumb and the index finger. It will be more around 80 to 85 degree angle, but this is narrow. It will be less than 50 to 55 degree angle. So this means the pelvis is very small, but here it is adequate. Okay, this is the way you're supposed to check it. You can check in this way also. Okay, as I showed in the previous slide. So you have to check for the TDO. TDO means it's a transverse diameter of the outlet. So you keep your hands fist like this. This is called as knuckles. It should adequate. If the pelvis is adequate, it will accommodate 4 knuckles. And this is the distance between the tuberous. Tuberous is the bone. Okay, this is a ischial tuberosity. Okay, where we sit. Okay, you should keep your hand in such a way that it is going to admit 4 knuckles. Check for asymmetrical or obliquely contracted pelvis. How do you check it? You should know this. We really can't assess, but people who have experienced will be able to identify. So let me know what are the different types of asymmetrical pelvis. This is Naegeli's pelvis. So what happens here? One sacral ala. This is ala. Okay, this is sacral ala, and here there's no ala. And here the affected part will be straight and more marked in the outlet. So its iliopectineal line will be almost straight. Robot pelvis. Here the sacrum is fused with the innominate bone ilium, and both the alas are absent here. This is soleotic pelvis. Can you see this? Mostly followed by the tuberculosis or rickets. This occurs, and the sacrum is tilted backwards in the front part and forward in the lower part, and ultimately forming a narrow and a straight one over here. Okay, so the anterior posterior diameter, the inlet will be increased in the beginning, but as soon as it goes out, this will be narrow. So the angle also will be extremely like funnel only. Malpresentations are more common. Osteomalacic pelvis, the name indicates deficiency of calcium and vitamin D only. The pelvis will be like this. So the sacral promontory is pushed downward and forward. Okay, downward and forward. And the lateral pelvic walls are pushed inward. So look at this one. Okay, it's pushed inside. And the shape of the inlet that's forming a tri-radiate. It means 1, 2 and 3 radiate, somewhat like this. And sacrum is marked shortened and coccyx is pushed forward. Normal vaginal delivery is not possible. Racket pelvis, sacral promontory. Yeah, look at this pelvis. Okay, this sacral promontory, this is the first bone of the sacrum. Sacral promontory is pushed downwards and forwards, forming a reniform. It's a kidney shape. Okay, the kidney is somewhat like this, right? So it forms a kidney shape over here. Okay, and inlet and anterior posterior diameter is more increased without affecting the transverse diameter, and the sacrum is actually flat and tilted backwards. Sharp angulation is there. If there's going to be sharp angulation at the sacropoccygeal joint, again there will be the progress will be obstructed, and the body weight will be transmitted through the ischium in sitting position as well, widening the transverse diameter of the outlet and the pubic arch. So, hand is withdrawn from the vagina, note for the blood or the amniotic fluid, and clean the mother and reposition her comfortably. Document time and findings, replace equipment, and the main purposes we already went through. Okay, so let me revise it. So we found effacement, dilatation, position, consistency, and all are the cervical factors. And we check for the membranes whether it is ruptured or intact. And we check for the presentation whether it's cephalic presentation or malpresentations. And we check for the position of the fetus whether it is going to be left occiput anterior or whether it is going to be a posterior position. And we check for the station at the ischial spines by checking the fetal head, and we check for the molding, overlapping of the bones. We check for the progress of the labor. Every hourly, it should dilate 1 to 1.5 centimeter. 1.5 centimeter occurs in multipara, and the dilatation is going to be 1 centimeter per hour. In primary, it is normal. Okay. So types of the pelvis we found, right? Different types like Naegeli's pelvis, Robert pelvis, and all. And to apply the fetal scalp electrode. This you should know. Nowadays it has been avoided because it's an internal procedure. So when there's a rupture of membrane, they will insert this wire and attach it on the scalp just to check the fetal heart rate. And there'll be one more wire too that will be inserted, and that indicates the uterine contractions. So if you have any doubts, comment below, and